Hi, and welcome everyone to Phytel's Executive Webinar Series. Today's presentation is entitled Big Data Analytics and Population Health 2.0. We are happy to be with Dr. Anil Jain, Senior Vice President and Chief Medical Officer of Explora, an IBM company, now part of the IBM Watson Health Unit. Today's session is moderated by Karen Handmaker, Vice President of Population Health Strategies at Phytel. Before we begin, I'd like to review a few housekeeping items. First, you have a control panel on the right side of your screen. You can minimize and expand the panel by clicking on the arrow in the upper right-hand corner. Second, you could submit questions using the question panel located near the bottom of your screen. We'll try to answer as many questions as we can at the end of the presentation. If you have any questions that are not answered, we'll respond to you immediately after the event. And then finally, any registrants who are registered for this webinar will receive a copy of the presentation along with the recording of this webinar within 24 to 48 hours. The information will be sent to you via email in which you registered for this webinar. So just please make sure that you do review your emails. At this time, I'm going to turn it over to Karen. Karen, you may begin the webinar.
Thank you, Renee. Welcome, everybody. We're very pleased to have Dr. Anil Jain do the webinar for us today. Big data and population health management and analytics and risk stratification and all the tools our clients and our industry needs to manage populations and value-based contracts is extremely important. Dr. Jain, as Renee said, is the Senior Vice President and Chief Medical Officer of Explora, an IBM company. And Dr. Jain will tell you more about his background as part of his presentation, but want to emphasize that he developed the innovations that are the foundation of Explora and while he was at the Cleveland Clinic. So we are especially grateful to have him here and very proud to have him share this webinar. Anil, Dr. Jain.
Thank you, Karen. Can you guys all hear me okay?
So far, so good.
Yeah. Okay, great. So thank you, Karen, for that introduction. So the couple things I want to highlight about my career that is relevant for the conversation we're about to have is that I have gone through a series of, I would say, health IT projects along the way that have shaped my understanding, and I think in many ways the perspectives I bring are shaped by the EMR implementations that I've been involved with for the past 20 years and some of the population health activities before they were traditionally called population health, some of the learning collaboratives that took shape within the Cleveland area and across the country, some of the big data strategies around net new knowledge discovery. So I'm happy to answer any questions from those perspectives, and some of we'll see will be colored by those experiences, the good and the bad. Now, when I began my career as a medical student, I remember starting class sometime in September of 1991 at Northwestern, and this is right after I finished my biomedical engineering degree, and I thought to myself, what did I get myself into? Our attending physician threw a Time magazine cover on our table during a seminar and said, aren't you guys glad that you are going into medicine? Healthcare is a mess. And the reality of it is that healthcare has been a mess and certainly hasn't been a system. Those of you that are part of a system know that it operates very independently, like a fragmented sort of grouping of various folks, providers and doctors and all the ancillary services. And along the years, in '96, I was just finishing up my first year of training, and there was in the lay press lots and lots of material about how healthcare is in a terrible state. In 2008, it's when I decided to take some of what I had developed at the Cleveland Clinic, the precursor in many ways to the Explora data platform, and this is what was happening. Basically, folks were talking about the sorry state of American health. March 2013, I had the misfortune or fortune of having given a lecture in Sweden where I was basically trying to explain to them how big data was going to change healthcare, and one of the attendees in the audience raises his hand and said, wait a minute, Sweden, we're number 1 in healthcare, and the United States, you guys are number 19. What can you teach us about healthcare? And so along the way, healthcare has been a problem, at least the way it's been delivered. And then recently, this past January, a wonderful article about how an individual has taken apart their costs incurred in having heart surgery and tries to explain what some of the challenges in healthcare are. I think for most people on the call right now, we understand that it's a bit of a challenge. We certainly don't operate like a healthcare system. We're more of a cottage industry, and there are misaligned incentives across the board. So why is this relevant? Well, Watson Health recognizes this as well. So when Ginny Rometty, the CEO of IBM, announced the formation of Watson Health, she described it and said that we're going to make sure we do our part to change the face of healthcare. But she also described it as our moonshot, meaning that we are going to make investments just the way that the Apollo program made to get a man to the moon. But the real benefit is all the spin-off, all the wonderful innovation that happens on our journey to get to the moon is what we all recall and is becoming part of our everyday lives. And in many ways, Watson Health feels the same way. It's all the spin-off benefit of having Explora come together with Phytel, with Explora and Phytel partnering with folks like CVS Health and Medtronic and Johnson & Johnson to be able to use the various collections of data that exist out there to do the right thing for the right patient at the right time every time. Bringing in partners that have a lot of data that we're going to talk about that really changes the way we might approach patient engagement and certainly the way we might approach population health. But this journey around being data-driven started some time ago, and this was a meeting of the Institute of Medicine and the learnings from it. But a couple things I want to point out here. And it's a wonderful report, and the reference is below, and you will get these slides, so don't have to memorize every reference. But the couple of things I want to point out here is they talk about the digital capture of the care experience as being a vital component of the continuously learning healthcare system. And I know many of us who come from healthcare systems, and I still practice occasionally at the Cleveland Clinic. And so I absolutely want to consider myself the best practicing doc when I do practice. And I would want to feel like I'm part of a continuously learning system. But one of the things that they talk about is the digital capture of the care experience. And when you talk about that, you have to talk about data being a vital component of that. And then we'll get to this in a bit, but it's not just about the data, it's about the actual insight that we gleaned from it. It also talks about engaged, empowered patients. And I'm not going to go through the entire report, but it's a report worth reading in terms of looking at how the IOM looks at the importance of having a data-driven, based on value and science, healthcare strategy. Now, last week, the Office of the National Coordinator, the ONC, put out a final report. About a year ago, they embarked on this interoperability strategy, but October 5th, they published the final report. And a couple things I want to point out here, and it's a pretty good read. There's an executive summary, fortunately, that we should all, if you're in the space, try to get our arms around in terms of thinking about the way that the federal government is pursuing the IT interoperability roadmap. And what they did was they took a lot of our colleagues and smart people and put them in a room and said, how are we going to take a bunch of the different technical aspects of what we must do around consistency around data, making sure we're matching the right data to the right patient, things that are basic bread and butter for any kind of population health strategy. How are we going to put our regulatory might and our federal dollars to come up with a strategy? Now, it's a great report, and again, the reference is below. But challenging part of this for folks in the trenches, folks like us who are trying to do the best thing for our patients, is that much of the consensus takes us out to 2021 and beyond. What are we going to do right now? What are the drivers that are influencing our need to invest in technology and invest in the analytics? Most of us, when we talk about making investments or running an analytics project or a big data project or a population health strategy, it's about improving clinical outcomes. But if you have no money, you have no mission. So it's also about reducing the operating costs and inefficiencies that have gotten introduced into this cottage industry rather than the healthcare system. It's also about enabling the value-based care and population health, where we're going to talk about in a few minutes. But these are the main goals that folks today are investing in analytics. The Deloitte Center for Health Solutions did a wonderful survey, and again, this is just a snippet of some of the wonderful learnings that you can get from this, and the references listed here. One of the other areas, though, that's listed that we typically don't think as being part of our agenda, or at least part of the population health agenda, is to drive innovation and support research. There is an incredible emphasis on basically doing what we know today. But where's our next generation of knowledge going to come from? It's going to come from innovation and research. And we want to make sure that any kind of investments we make in data and analytics and population health for that matter, it supports the innovation and net new knowledge discovery that's important for the next generation of insight. Now, this is a report done by the IBM Institute for Business Value in conjunction with MIT Sloan Business School. What they try to do is they try to understand what are the goals that healthcare has around analytics versus other industries. And I think many of us will recognize that, again, we want to improve clinical quality and patient safety. We also want to do this fifth bullet in the first area, where we really need to understand how to improve customer satisfaction, acquisition, and retention. One of the biggest challenges that we're going to have as we improve our interoperability in healthcare is how do health systems stay aligned with their patients. If a patient can go to any health system and get their care because everyone has their data, then what drives that loyalty? So it's an important part of the kind of analytics that we all need to be thinking about. And also understanding how do we end up improving our operational effectiveness. Now, interestingly, a lot of folks who come from industries outside of healthcare think of the healthcare sort of conundrum as just another. They think of themselves as a hammer and think of healthcare as just another nail. But we know, those of us in healthcare know it's different. We know that it's different because there are issues around the disparate data sources. So this is another sort of graphic from that same report from the IBM Institute of Business Value. And they talk about the big differences are that healthcare providers and payers are looking at integrating a wide variety of disparate data sources. They're also looking at consistency and standardization issues that other industries may not have. Like in the banking industry, if I have an ATM card, I'm not worried that I'm going to go to an ATM machine and not have it give me the money I need, or that it's going to somehow mess up my balance on my bank account. There is a communication that occurs on a regular basis between the systems, and interoperability has not been an issue. But in healthcare, it has. The ability to protect that data through HIPAA high-tech requirements has also been a difference in the healthcare industry. Now, let's turn to big data. This is a Gartner hype cycle from report from 2013. Now, notice where big data is. It's at what we call the peak of inflated expectations. Now, we teach some of our young folks who come to our organization that this is not the place you want to be. You don't want to be here because it's hard to stay up here. Where you want to be is in the plateau of productivity. That's where you all get the most value from making investments in big data. But in order to get from the peak over to the plateau, there's a trough of disillusionment and a slope of enlightenment. And hopefully the rest of the conversation will be, how do we do that? How do we get down the trough and up the slope and into a plateau of productivity? Now, one of the other things I often talk about is that healthcare did not, certainly Explora did not invent big data. It's been out in the lay press in other industries for quite some time. In the nuclear physics industry, when you smash two atoms together, as one of our data scientists tell me, there's a huge amount of data generated, and much of the big data paradigm has come from there. It's come from the financial industry and so on. It's been out there, and so healthcare has embraced it. But like many things, healthcare is beginning to understand the power of tools that big data represents. So what is big data? So many people think of it as 3 or 4 V's. I'll start with the 3 V's. We'll add a 4th, and then I'll tell you what I really think it is. So some people will say that it's about volume and variety. A lot of data coming at you very quickly with all different shapes and flavors. That could be big data. Now, one of the other things that we typically will think about is veracity. How accurate is the data? How truthful is it? How truthful is it representing what I'm interested in? So those are the 3 or 4 V's, if you will. But the reality of it is that it's any data that is not readily amenable to traditional tools to either store that data or to analyze it in traditional ways. That can be considered big data. So if you can't open up Excel and bring that data and then crunch those numbers, that's big data. If you have so much of it, it doesn't fit into your system or onto your server, that's big data. Bottom line is that if you're going to have these types of big data challenges, there has to be people, process, governance, and technology to address big data. Now, why is there big data in healthcare? For years, I've been talking about the perfect storm in healthcare around big data. We had, of course, the 2009 ARA meaningful use. We sometimes call it stimulus or cash for clunkers. Some of the providers I would talk to around meaningful use, there for the first time they were being incentivized to bring in an electronic health record. So we had a abundance of health IT spend, resulting in EMRs in doctors' offices and in hospitals, and HIEs, resulting in large amounts of data. Now, the other thing was the 2010 Affordable Care Act. What it basically did, as we all know, is that it promoted new delivery and reimbursement models. In order for those delivery models and reimbursement models to work, in order for providers and their stakeholders to make sense of it, we needed data, and that generated lots and lots of data, but more importantly, it generated a demand to analyze that data. Another area is exogenous data, where we have and I'll show you some of the statistics on this. It's pretty staggering. We have a growth in wearables. We have a growth in social media. And of course, now with the sub $1,000 genome-wide sequencing, we have a growth in genomic data. And there was a recent announcement of a $15,000 a year cholesterol-lowering medication. You better believe that someone is going to want to do a genetic profile on that patient before prescribing such an expensive medication. And so where is this data going to go? How's it going to be used? We got to think about that, and all that comes together to create this big data challenge in healthcare. Now, I think many of you who are living and breathing electronic health records don't need me to tell you that there's been a huge growth in EHRs, like as a meaningful use, but others because it was the right thing to do for their health systems. Whether it's the basic system or a certified system, there's been a growth. Now, that's great. It's a great way to manage patients, but we're going to show you some data that suggests it may not be the best way to deal with big data and population health. Now, at the same time, the HIEs, at the same time, the EMRs were being funded through meaningful use or the High-Tech Act. There was also health information exchanges popping up in various markets, some that have done great, some that are still struggling to connect different healthcare systems with each other so that the patient's data can be coordinated. And again, you can see here that it has not necessarily caught on as quickly as the EHR has. And we'll get to why this is important, but the bottom line is that people need a way to connect data across their community. And HIEs are not moving fast enough. So let's talk about the patient. So when I see a patient, oftentimes I'm focused I'm an internal medicine doc as really on the clinical factors. I'm looking at their blood pressure, their weight. I'm having a conversation about some of their habits, and some of that will fit into the exogenous. But in my 15 minutes that I have with the patient, I'm expected to collect all the data that I can. But the reality of it is, I only see that patient for 15 minutes every 3 months, so maybe an hour out of the year. All the other times, this particular patient is generating data through their habits. They're generating data through their environment. They're generating data because of who they are and where they work and what their family looks like. And certainly, they have a bunch of genomic data that's sitting there. So we typically think of the 10-30-60, 10% being clinical, 30% of it being genomic or gene expression data, and 60% being exogenous, the environment, habits, and the Fitbits, if you will, and all that things that we are beginning to understand have a great impact on quality of life and on the impact of disease development. And I'm not going to talk about the actual space and storage that it requires, but it's a lot. It's a part of big data. Now, the wearables have grown significantly. This top graph here, you can see that in the wearables, healthcare is the #1 growing area. Many insurance plans are beginning to subsidize the Fitbits or Fitbit-like devices. Many folks are being sent home from the hospital with some wearables so they can make a difference in their post-care discharge follow-up, etc. And in terms of the social media, you can see some data from HIMSS that social media is being embraced significantly within the healthcare space. And then with genomics, two reasons that are driving the growth of genomics. First, the cost of a genome-wide sequence is coming down, and the growth of personalized, individualized, tailored therapies is going up, which means that we need to know who this particular therapy should be used on because it's so expensive. And so this process is going to create a deluge of genomic data. And even if you take the most conservative estimates, it will be phenomenal in terms of how we're going to have to address all this. And as a doc, I don't want to see data. I want to see insights. And I think that's part of the big data and population health story. If I'm going to impact my patient's health, it's not going to be because I get a couple terabytes of data in front of me on my screen. It's going to be because I'm being given actionable support during that particular visit. So traditionally in healthcare, we've done a great job with looking in the rearview mirror. We get reports and we're able to look at a couple different areas. We can maybe even drill down into different areas that might need improvement or drill down into patients that might need intervention. Perhaps even get alerts in the EMR about things that we should do. But that's not where we want to be, right? We want to be able to understand why something is happening and then look at what that trend might tell us, predict what's going to happen next, and then do something to avoid that unintended event or to promote that positive event from happening, basically to optimize the way we do things. That's the real opportunity with big data. Because of the nature of the tools that we use, it's been easier now for us to think about how we can analyze, forecast, predict, and prescribe, if you will, or optimize actions that need to be taken. Let's go back to that to the hype cycle. So this is from 2014, a year after the last one, and you can see it coming down. Okay, it's not at the trough yet, and it's certainly not in the slope of enlightenment. It's certainly not the plateau. It's coming down. Why is it coming down? Well, there are obstacles. First, there's obstacles in analytics, and many folks like Vital and Explora and others, we exist because these challenges exist, right? The ability to get the data, the ability to share information with each other. We have all been in rooms where folks may not understand the value of sharing the data, whether it's the insight or the raw data itself. But there's also skills that are lacking, the ability to use the data. And then, of course, there's always another priority that takes higher precedence than the kind of analytics that we need. Who's sponsoring the activities and owns this particular project? Is it their day job, or is it something that they forgot to take a step back when they were asking for volunteers to do this? These are all challenges that happen. This is from 2012, but let me show you that in 2014, when they surveyed a whole bunch of ACOs, it was a little bit of the same and a little bit different. So when they talk about infrastructure, the challenges were interoperability, figuring out who's going to pay for it, how does it integrate into the workflow of the clinical system. Providers didn't really know what to do with it. They weren't trained on how to look at risk. And there was this idea that I always talk about, is that were we measuring what matters, or were we just measuring what we were told to measure? And so there was issues. And when it came to the analytics, you saw similar concepts around getting access to external data. And what they mean here is that our health systems have been challenged with getting claims data from their payers. That's an important part of, as you know, population health, and we'll talk about it, but that's been a challenge. And then again, how do you integrate that into the data set that might be filled with clinical data, but now you have claims? How do you bring them together? How do you integrate that into the workflow of the care manager or even the provider? And then how do you make sure that the data is of good quality? So here's another study done by Deloitte back in 2015. And what they basically said was, okay, we got a few years now where people have been dealing with ACOs and dealing with some of this thing. what are the biggest problems that you perceive in being able to get data, big data, run out analytics, and what are the barriers? They talked about culture and politics being number 1, ownership of the projects being number 2, and skilled resources being number 3. But look what's happened. At the very bottom is data access. It's no longer about getting access to the data. They are getting data now. They just don't know how to use it, who's owning that particular project, and they don't have people to make sense of the data once they do open up those files and look at it. And they're not necessarily aligned, the hospitals and the community. In some cases, they need to look to third parties like Vital and Explora and others to help them understand how do we create governance around this. So this is from, I believe, about a month ago. This is from the Robert Wood Johnson Foundation working with Harvard and University of Michigan. And what it basically talked about in one of the chapters, which is a very good read, that there are big data adoption challenges across healthcare systems. And now this is specific to big data as opposed to data in general. And it talks about people still asking the question, is it secure? Because in general, big data is more likely to live in the cloud. And so when that happens, like what Vital and Explorers do, you start having questions that folks need to answer. And if they don't have a partner to help them with this, they struggle, and then they get into analysis paralysis. Is it secure? Who owns it once it's up there in the cloud or in the big data platform? How do you access it? How timely is it? And how do you make sure it's of high quality? And then do I, as an organization, have the skills and bandwidth to actually analyze it? Here's an example of a study that I and my team did back at the Cleveland Clinic a few years back, where we looked at, if you look at the diagnosis data in the EMR, how good is it? If someone in the EMR says that this particular patient has diabetes, how sensitive and specific is that particular thing? Now, the reason I bring it up is that one of the challenges of using data has been trust of the data. And no data in the EMR and no big data that's coming from all these different sources can be used as is. We have to go through a validation process. We have to understand how good a piece of data is versus how not so good that particular piece might be in terms of accuracy. So I encourage you guys to look at different validation processes to understand what's good and what's not, and then to tweak your projects around those. This is a slide to demonstrate data governance. So many folks who are embarking on population health and big data start thinking about, well, if I can just bring all this data together, I can start looking for interesting patterns, or I can start identifying patients who need certain things done, but they're building predictive models, or they're trying to ascertain patterns. One of the cautions I will share with you is that we have to be careful that we balance the privacy protection that our patients need to have. We need to respect their privacy when we work with their data, and the value it provides when we're trying to address questions. So one of the things that you'll have to answer is whether you need to de-identify, or at least statistically shield or statistically de-identify certain pieces of it before you do your projects. The nice thing about working with partners who have some expertise in this, we do this sort of a thing for our folks. But this is something that you'll have to struggle with if you're trying to do it yourself. So you got big data, you got population health, you're going to hire someone, or you're going to look for someone to help you with the big data in addressing population health. Who do you turn to? Well, most of us will say that in order to harness big data, you need data science. And data science is not yesterday's data analysts. It is not yesterday's data analyst. You cannot just take one of your data analysts and stick a label and call them a data scientist. It's not. It is a multidisciplinary way of addressing a need that combines a whole bunch of different concepts together. Now, it doesn't mean that there aren't some data analysts that can grow into a data science role, but there needs to be additional training and education. So what do I think of as a perfect data scientist? Well, it's one that combines what I would consider to be hacking skills. When I say hacking skills here, I'm talking about who understand how to code in a computer and solve problems, not someone who's doing an illegal activity. And you combine that with some math and stats knowledge. And then you combine that with substantial expertise in what we're studying. And that intersection is a data scientist. Now, in practical terms, the way I tell my data scientists are that you're a good data scientist if you answer the question I should have asked you instead of the question I asked you. Meaning they know enough about the material, they know enough about how to solve problems, and they understand enough about statistical significance that they lead me down a path that makes sense. Now the problem is that we have a shortage right now of these folks. And so one of the advice I give health systems and others is that rather than trying to build out an army of data scientists, is to find partners who can augment your skills that you need and work with people that can be there for the kind of projects that you need. It doesn't mean that you don't need any. You should have a few, but you certainly don't need an army of them because they're hard to find. Now, here's a Nielsen this is a Nielsen Consumer Insights. I think it was a Harris poll, I think, done back in February and March of this year. They've interviewed 1,000 medical professionals, doctors, chief medical officers, care managers, nurses, and what's interesting is that more than half of them said that Pop Health is a top 5 initiative for them, and that 9 out of 10 folks agreed that investments in sophisticated data analytics technology was critical for effective population health management. But more than half of them, more than half the nurses and case managers who do the real work in many cases around population health say that the EMR was not adequate for effective communication. And so the question that I have is, are the investments that are being made, are they being made in the right spot? The EMR certainly has a place. It's an important part of the healthcare system, but it may not be the most important part when it comes to the analytics and to the population health that needs to happen. So what does a big data platform look like? What does a big data analytics group, how do they get started? This is a wonderful sort of framework that Raghupati and his colleagues put together in, and published in the journal that's listed below. And basically they talk about 4 things. They talk about sources of data, transforming that data, using tools to go through it. And in this conversation today, we're not going to go through all the big data tools, but these are some of the names that if you are into big data, you should probably get into, and there's a reference down below that you can use to get at the article. And then the final piece is the applications that actually serve up the insights. Now this is a framework. What does a real one look like? What does a real big data platform look like? So here's an example of what we're doing with Watson Health, and the ability to take that bottom layer, if you will, and acquire data, regardless of where it's coming from, regardless of which EMR generated it or which information system has it, regardless of the venue of care. You have to bring that in through the transformation layers that go and standardize and identify the patients that as the same Mr. Jones who walked through the hospital emergency room door was the same Mr. Jones that walked into the community physician door. We put their data together so we avoid a readmission. Things of that sort are what the transformation layer does. Now, why is it big data? So if you look at these boxes here, one of the things that make it sort of capable of consuming large amounts of data and processing it is we typically think of as massively parallel storage and massively parallel processing. Simply put, that means that if in the old days I would go out and get a new computer when my current computer wasn't fast enough to keep up with the newest operating system or the newest version of Office, we would turn in our old Pentiums and get, you know, a i7 laptop with a bigger screen and perhaps more horsepower. Well, in a big data world, the paradigm is simply, rather than buying a more expensive, faster single computer, put a whole bunch of them together, put a whole bunch of common ones together, and you'll have more capability. It's the reason why we don't simply just keep feeding an oxen to pull a bigger load. We put 2 oxen to pull a cart. It's the same reason why we go for a V6 instead of a V4 when we want more power in the car, not just make our cylinders just bigger. So the concept is you have a parallel bunch of computers working in tandem to give more power. Now, there's a purpose to all this, right? So we talked about the applications that serve up insights. So within our world, our healthcare world, there are really 4 areas that we focus on, which is health services and clinical research. Again, that net new knowledge discovery, measuring what matters, knowing that what we do works is important. Health and wellness. So before a person becomes a patient, they're a consumer, and we have an opportunity to intervene on them. Population health management, those risk-bearing contracts, and making sure that we use our big data capabilities and our analytics, take all the data we have at our disposal, and impact the population. And then value and efficiency optimization. We are, in many cases, I said earlier, no money, no mission. If the healthcare system can't run efficiently, it won't be able to serve the patients that it needs to serve. So do they understand by using data where is there waste, where are there opportunities for optimization? Now, here are a few examples. So one of the things that we often do is we try to understand, is there some patterns about a population that we're being expected to take at risk? Often what's happening is employers and payers are coming to health systems and saying, I have a group of, let's say, 50,000 patients. Will you be willing to take care of them? And if so, what does that look like? What does that overall thing look like? And what our providers are telling us is that, you know, we don't have much visibility as to what those patients look like. So we're able to give them sort of descriptive statistics on what that population looks like and utilization patterns by combining the claims data with some clinical data, doing some geographic mapping to understand where primary care docs are located and specialists are located, who's in the network, who's out of the network. Combining that with clinical performance. If a health system is being asked to take on a population of patients in which 10% of their patients are diabetic, and that health system doesn't have enough endocrinologists or aren't doing so well with diabetes quality measures, then they might put themselves at risk. So it might help them understand where the investments might need to be made. These are all examples of descriptive analytics. But another piece of it is in the population health world would be being able to risk stratify a population and then provide insights so that we can understand who are the most critical 1% and the highest 4 or 5%, and the ones in the middle where we can have a less intense type of intervention, and maybe the ones that are very low complexity that we can do automated outreach in the way that, for example, Phytel does. So these are all important ways of doing it. But why is risk stratification so difficult? Well, the first thing is that, and I'll share a story about when we were seeing patients that one of our environmental services folks could predict which of the patients in the ICU were sickest in the beginning, more so than our medical students could. Why is that? Because the factors they were using to risk stratify were the number of IV poles hanging, because they basically said if the more medications that a patient in the ICU was being given, the sicker they are. So risk stratification could be simply something as simple as observation. It could be something as simple as asking a nurse what are their thoughts about whether this patient needs certain intense therapy or not. But in order to scale that, we need computational analytics. We need some way of scaling and automating the quantification of risk. And some of those models, like in Medicare Advantage, for example, they use HCC scoring to understand that risk. But one of the things that I'm going to share with you in a few minutes is that sometimes the current risk models are just not good enough for the kind of work that we want to do. So if you do have that risk score and you do have that ability to intervene on a patient, how do you make that information actionable at the point of care, or at least in a way that's digestible? And so one of the other parts of big data and the other parts of having control and access to so much data is how do you convert data into information and into visualization? So if you have lots and lots of data, the trick is how do you distill it down to color? How do you distill it down to trend? How do you distill it down to basic feedback that you can give a provider to help them make a decision? So here's an example of putting risk scores with color coding for high risk, intermediate risk, and critical risk. Here's an example of trending where one can determine whether you're going in the right direction or you're going in the wrong direction. Now let's go back to that risk. So we talked about how risk has many forms, but most of the time when you're looking at these automated models, most of them are relying on demographic and medical conditions. So how old is the patient, are they male or female, and what diagnoses do they have? But we know, as clinicians we know, and those of us on the call who are clinicians understand this, that the more medications that a patient is on, generally speaking, the more it takes to get them under control. The more procedures we do with that patient, generally speaking, the more sick they are. So not including medications and procedures is a miss for some of these risk models. And I'll show you in a little bit, when you add those on, you get some profound results. Most of the models out there from a current performance just are all very similar and just don't do well. And most of them, if you start using them in clinical practice, only exhibit modest performance. Most customers that consume risk models, they want a better, transparent model. And so how do we do that? Well, first thing is that when you evaluate risk models, you have to know what your purpose is. And this is in your handout. I'm not going to go through all these, but there's an art to it. So when you do have that data scientist working with your solution partner or within your own groups, you have to go through a list and say, why am I building this and what does it mean and how do I educate my constituents around it? But big data improves these models. Big data adds a certain amount of volume with the data. The more data you start with, the higher likelihood that your predictions will be more accurate. Use some more data points so your predictions will be more accurate. The more variety of data you have, the more likely that your models will be better in a predictive way. And the faster you bring new data in, the more likely you can to self-tune that model or to update that model as needed. And the other thing is that, remember that concept of massively parallel computing and storage, that big data Hadoop engine that I mentioned earlier? Well, if you have parallel computing, you can actually do the crunching, the science and math of the models much more quickly as well. So here's an example, what we did. We took the demographics and diagnoses, like what many other folks are doing, but we added procedures and medications. And what we were able to do is demonstrate a much higher predictive accuracy. And R-squared, for example, if you look at the Medicare predictive model, looking at this year's expenses, meaning observed versus expected, what you find is an R-squared of 74.2%. What does that mean? That means that the model was able to explain 74% of the variability in cost. Another way of looking at it is that from a population health point of view, the health system was only taking about 26 cents to the dollar risk, if you will. Now that might seem like a very low predictive accuracy, but the next, the nearest folks, some of the CMS models, for example, were in the 30s. Okay, so this is a profound difference, but it's not surprising. We just have more data, and we're using different types of data, procedures and medications. After all, we have 55 million patients aggregated across our benchmark network, so we just can build a better model. Why? Why do you need a risk model? Well, there are 4 scenarios, and I'm going to keep moving on, but this is all in your handout. You can use it to identify who is going to cost from a utilization point of view more next year than this year, or than others, so you can apply the resources appropriately. Can you risk stratify them so you can focus on the highest risk groups? Can you tell which of your providers and practices are working as hard as they should, meaning that they're seeing a lot of patients who are sick versus those that might be seeing a lot of patients who are less simple and therefore may be able to take on more, or vice versa, the docs who are taking on complex patients, maybe they should back off and be given more time to work on them. To benchmark performance between providers and practices or between different plans. The risk model, basically think of it as an equalizing fudge factor, if you will. Why do all that? Well, we talked about the risk stratification, being able to find the critical patients who may be catastrophic, some that are chronic, some that might be at risk of developing a disease, and others who you want to keep away from the hospital because they're healthy, and they're likely to stay healthy with a little bit of support. And again, the ability to target different types of interventions for different groups starts with risk stratification. Now, how does population health management intersect with population health analytics and big data? Well, if you can take all this data, harmonize it across, create a single longitudinal record, risk stratify that patient, and then work seamlessly with a care management platform like Vitel, then you basically can create that seamless ability to impact a patient with the best, highest quality, timely data that you might have. So here's a couple quick examples, and I wanted to make sure I left plenty of time for questions. So what does this mean in practical terms? We have about 60 articles published in the peer-reviewed literature that leverage the ability to take all this data that's coming at us. It's big data. It's lots of variety of data, clinical, operational data, financial data. And do something useful with it in the sense of predicting something that could be helpful in population health. So here's an example of where you can combine various clinical data from, let's say, a STS or an ACC registry that cardiovascular docs might need to manage, and combine that with the claims data coming out from Medicare and understand, could we have predicted the cost of an angioplasty procedure before the procedure, right when we scheduled it? Now, how could that be important? Well, imagine you're in a population health program where you're able to give the employer or a payer a predictable price, maybe 3 different bins of pricing, and give them some confidence that the price won't be everywhere, that we can reduce the variability that is driving healthcare systems and employers and payers. It's driving them crazy because it's difficult to plan anything when you have such variability. So that's one example. Here's another example. We take all this information using big data principles, be able to do a study in 10 weeks, 100 hours of a person's time, a study that has 10 times as many patients, that essentially replicated the results that a 12-year study in Scandinavia took. And again, it's not about the science here. It's about big data principles and tools, being able to shorten that time between bench to bedside and perhaps the bedside to the bottom line. That's the goal, after all, in population health. So one of the things I share with folks is that if you're going to do big data, and especially big data in population health, obviously, other than finding a partner, finding a good strategic partner and working with them to understand your issues and help solve problems, make sure you have a strategy before you have a technology. Oftentimes, we walk into health systems where they are sitting on data files that they have yet to open, and they're not entirely sure where they begin. So where does the health system want to be a year from now, 2 years from now? Where do you see yourself having challenges when it comes to big data? Shape that so that you can have meaningful conversations. One of the other things that is evident from not only my observations working with folks around the country, but also from numerous surveys, is that cultural alignment and governance is vitally important. The people, process, and politics of getting around your big data is critical. You do not want technology to dictate people, process, and politics. You want that solved before you put technology in place. Otherwise, adoption will be a problem. The analytic use cases should be developed with a crawl, walk, run mindset. Otherwise, we never see progress, and you won't get the buy-in. Identify the skill gaps early so that you can start identifying people that you need to bring into the system. Educate the clinicians on actuarial risk. As much as they understand clinical risk, they need to understand actual risk in 2015. As we go on to take 80% of our patients at risk in Medicare by 2017, it's important that they understand actuarial risk, or at least have tools to understand it. And I feel that risk stratification is the only way to really balance the outcomes we need to achieve in population health and to bend the cost curve with the limited resources that we all have to target this. So I'm going to stop here for any questions and answers.
Thank you, Dr. Jain. We really appreciate that. That was an excellent presentation. We have had several people ask us a question that is specific to Explora and Vital. Can you explain, describe the difference, or I'd rather say the synergies between Explora and Vital?
Absolutely. It's a great question. So Explora is a recognized leader around aggregating large amounts of data from disparate sources. So think of it as a big data platform. And to be able to run out in a massively parallel computing platform, the analytics required to understand trends on the population, to understand in a standardized way some of the care gaps, and some of the predictive models that identify patients who might be at risk for readmissions, prospective utilization risk. Think of it as the big data aggregation and risk analytics platform, whereas we take that information and then make it actionable from a care management point of view within the Vital platform. Now, we're talking about Explora and Vital as if they're two distinct things. And yes, today, 6 months from the time we were acquired by IBM, they are somewhat distinct. but that is moving very quickly to an integrated solution in which that aggregated data and analytics will shape the way PhyTel picks that information up and allows a patient to be engaged upon with the right modality at the right time across a longitudinal data set, and allow that provider to have, and that care manager to have a fully engaged experience with that particular patient so that we have the right outcome happen. So it's really about data aggregation analytics for Explorers, and it's about patient outreach and patient engagement and care management for PhyTel.
Thank you. Another question is, talk a little bit about the future. What is cognitive analytics, and how does that fit into the big data picture?
Great question. So much of what I described today, because you can't cover everything in 1 hour, has been data-driven insights. And while natural language processing can help us drive additional information from unstructured documents like discharge summaries and progress notes, true cognitive computing and cognitive insights is where you start combining knowledge and reasoning. So imagine, if you will, actually you don't have to imagine it. Watson is doing this today. Watson is reading journals and textbooks and understands what the typical scenarios in which a particular course of action might be needed. So in the oncology world, if you have a certain type of tumor, Watson Oncology, for example, can tell you what the most appropriate protocol and pathway is. It does so by looking at the patient's overall description of what's going on with that patient, looking at the pathology of the tumor, and then combining it with all the journals and textbooks that it has access to, and suggesting, not telling, suggesting to the provider that the following course of action is most prudent, and then the provider can drill in and say, why is this the most prudent course of action? Now imagine that being applied to population health. What does that mean? Well, go back to what I said earlier about measuring what matters and knowing that what we're doing is the right thing. Many of us have been put in positions as clinicians to either comply with a guideline or do what we think is best for the patient and not do it. Right now, population health is based on guidelines. But with with knowledge-based insight from cognitive computing, we are in the position of saying to ourselves, can we actually do the right thing for that particular patient in the concept of population health? So it's really an intersection between evidence-based medicine and personalized medicine from a book learning point of view. Now you combine cognitive insight with data-driven insight with personalized medicine like genomics, then I think that's our future. But right now, data-driven insight plus cognitive gives us the ability to have book-learned what we think is going to work, does it work? So in the real world, things that happen in clinical trials and in books don't always happen. But the intersection of those two is a great augmented way of looking at insights for providers who are too busy to read all day. I mean, the latest study showed that an average doc would have to read for about 24 and a half hours a day in order to keep up. Well, last time I checked, there's only 24 hours in the day. And so there's no way that an average doc can keep up. So cognitive insights augments our ability to make decisions.
Excellent. Very helpful. Let's talk about pricing a bit. With value-based payment and capitation and bundled payments, I'm guessing that a lot of the detail might be lost that's used in some of the predictive modeling, but assuming we can keep it, how can we use that information for sharper, more precise pricing based on the health of a population or an individual?
So I think there's two different ways of looking at this, and I'm certainly no expert on pricing, but I would say that you could either do it based on cost. So cost-based pricing would imply that we understand what it costs as a health system to deliver a set of services, and therefore we can price it in a certain way. Or we can do it on value-based pricing, meaning that we are able to price something because we were able to avoid a complication by doing something. For example, sending a patient who has diabetes to a podiatrist on a regular basis, you may say, well, you know, that there's a cost associated with that. Yes, but if we avoid an amputation, how do you price that particular care management or that particular process of getting a diabetic's foot examined? So I think what's happening is there's an intersection between trying to understand pricing based on our cost of delivery and understanding pricing based on our avoiding complications that are quite expensive for the health system. And until then, it's going to be a little bit of both. I think you can absolutely get visibility onto each of those with big data analytics by bringing some cost data. And we're doing this with one of our health partners today, where we're looking at their cost of actually delivering the care, how much their reimbursement is, and seeing whether they can tweak it to be more competitive in the market. Of course, you have to be careful about those kinds of things as you start aggregating data from across health systems, because some of that goes to data governance, and we're not always going to be privy to how much other people are charging for things.
That's also very helpful. And then, Dr. Jain, we got a couple of questions about the intersection of big data and big security. How do we protect all of this information?
That's a great question. So I'm probably one of those folks, and I think I did a recent interview not too long ago where I commented on this. You know, so we think about the cloud, and we think it's somehow this mystical place up in the sky, and that somehow security is going to be more of an issue there than it is in our own data centers, for example. But that's not the case. In fact, in many ways, when you're in a cloud infrastructure, security can be enhanced because in some cases you're sharing the cost and the durability of the security with other folks who might also be leveraging that cloud-based solution. So whereas in your own data center, by the way, could also be considered a cloud, and you are, as most health systems are already working with partners and vendors who are working in the cloud. The bottom line is that when you're in a big data cloud infrastructure, you're sharing some of the costs of securing it. There are regulatory and audit processes that folks go through to ensure that, and HIPAA High-Tech requires certain things to be done, and no one should feel like it's any less secure than anything else. It's certainly much more secure than the typical sort of healthcare systems, virtual machines that they may have running in their data centers. Because of that, you know, the protection by sheer numbers in itself adds a level of confidence to most people.
One last question. You referenced a lot of Institute of Medicine reports, and a brand new one just came out on diagnostic error. How will the combination of big data and technology-assisted workflows and patient engagement and mobile technologies help support or improve diagnostic error, which is so fundamental, I'm sorry, to data quality and the appropriate interventions at the right time?
Right, right. So, for us, no one can really do a reasonable job at big data analytics without triangulating what they're most interested in. So anyone who relies on a single data point and doesn't rely on circumstantial evidence or a sort of a Bayesian approach to layering on concepts to get some confidence about the diagnosis is going to have to deal with the problem of false positives and false negatives. So to give you an example, if you have an incredibly intense intervention and a costly intervention that you want to offer diabetic patients, you could decide to offer to anyone with an ICD-9 code of 250.00, in which case you'll have a lot of people who really don't have diabetes receive this communication. Or you could say, I want them to have not only a diagnosis code, but I also want them to have a hemoglobin A1C of more than, let's say, 7%. And I want them to at least have been seen by a provider who typically takes care of diabetic patients at least once. And so you can reduce the impact of diagnostic errors. But the reality of it is when people like myself and my colleagues, busy practitioners, are the ones who are entering data into these systems, you're going to have problems. And the only way to get at that, which is one of the slides was trying to allude to around validation, is if you triangulate. And if you combine multiple pieces of data to get at a higher level of certainty, especially in those cases where you need life-threatening interventions. Now, if it's not a life-threatening intervention, then you can decide where your false positive and false negative line is. And certainly big data has a way of identifying those areas to providers, and providers have then a chance to intervene and update their systems to reflect that.
Thank you, Dr. Jain. Renee, I'm going to turn it back over to you.
All right, wonderful. Thank you both very much for your time today. The information you've provided is just absolutely invaluable. I hope that everybody on the call did enjoy this presentation as well. And as a reminder, we will follow up with an email that includes the presentation and the link to the recording. You should receive it no more than 48 hours. Also, please take the brief survey when you log off the webinar, so it'll help us learn more about how effective this session was, and will help us for any future webinars that we have. Again, thank you for your time. We will have a November webinar. Please look for that in your emails for the announcement. And have a wonderful day. We appreciate your time today. Take care. Bye-bye.
Thank you.